what kind of a form is usually filled in a facility-based near-miss review. These will be given as annexures at the end of the class. It is a facility-based near-miss review form which has the following headings, that is the name and address of the medical college or FRU comes first, then name of the nodal person, which is usually the chief medical officer or the civil surgeon. Then this is MCS number which is generated, then facility based date, month, year. So this is the entire form where the information is filled as full name, age, IPD number, contact number. This is the demographic details of the patient with address, education status, BPL status, date of admission, date of discharge, date and time when she became a near miss. That is, it goes to the extent of hours and even minutes. So the type of discharge, whether she was discharged on request. So the first section, it has almost 10-12 sections, where the section 1 talks about the general information of the patient, where we are talking about the epidemiology, name, address, education status, below poverty line, that is her poverty status, admission, date of discharge, date and time when she became near miss, the type of discharge, whether she took a voluntary discharge herself or by hospital on request, LAMA, that is DOR, LAMA, referred to other center, or even absconded. Then provisional diagnosis at admission is very, very important, and the final diagnosis at the time of discharge. Suppose she was referred as a case of alone as a case of postpartum hemorrhage, but the final diagnosis that you made at the time of discharge that she was having postpartum hemorrhage along with sepsis, along with severe anemia. So these are the other comorbid conditions which you could identify and treat at the time of discharge. Then there is the duration of hospital stay in days and hours, and also duration of ICU stay. Condition at the time of admission, it has to be mentioned here. So it is such a detailed form that it gives you a good kind of a review. You are able to identify the woman's conditions, whether she was a true near miss. Once you have such detailed forms for all of the patients, it can help you with good publications as well. And because it's a very systematic form, you do not have to think where you are, how to make a form, or how to get a better publication out of it. It's already available there by the ministry, and it is a standardized protocol for all the medical colleges on all throughout the country. Patient admitted in hospital with severe illness, admitted with no disorder, became near miss, admitted with disorder, became near miss. So these are the conditions, how the patient presented to you, what was the type of admission, whether the patient was referred to you, whether it was a self. Then when we talk about the referral, if referred from outside, number of places visited prior, specify type like public, how many places, PHC, CHC, first referral unit, then she came a tertiary care center. If she visited some private center, how many private centers she came to. So last 2-3 weeks back, I operated on, I did an emergency CS in the night, around 11 o'clock. Patient was trying for a normal delivery at a private hospital. She had massive APH without a low line catheter. It was probably an abruption case around 35 to 36 weeks. She had sudden leaking and underwent abruption. Her antenatal HP was 8.5. On table, it dropped down to something around 4 and 5. The patient was referred to us as a case of IUD. Like the gynec who referred the case to us said that I could not localize a fetal heart. Although when she was referred to us, we could identify the fetal heart rate, and some fetal movements are also visible. So, patient was rejected at 3 private medical institutions, like private medical practitioners refused taking up for a cesarean section for a supposed IUD case. So, we filled the MNMR form and we had to fill all of these things. She was admitted with disorder and became near miss. Patient admitted to the hospital with severe illness. Yes. How many private centers she visited? 3. Attended by doctor? Yes. From last visited place before referral was completed? Yes. Transportation provided from the referring facility? Yes. So illness duration. Sometimes patients are not provided transport facilities. They have to undertake their own private vehicles, where you will be referring it as no. Illness duration is duration from illness to first health facility in days and hours. From first facility to this facility, duration from admission to near miss morbidity. Status at admission, where they are to talk about the gravida, parity, abortion, life child, ANC, intranatal care, days since. So it's a very, very, very elaborate form which talks about very much detailed things, and it gives you a very thorough and comprehensive information about women's health and status. So you have to fill these conditions: whether she had hemorrhage, and was it because of some placental cause, late pregnancy bleeding, other than placental causes, was it scar dehiscence, was it a rupture uterus, other causes, intrapartum bleeding, postpartum bleeding, what is the cause of the postpartum bleeding she had, was it atonic, traumatic or mixed, whether the woman had infection like such as pre-existing infection which got worsened like an HIV, AIDS, malaria, dengue, scrub typhus or other infections, whether it was an antepartum, intrapartum, postpartum or post-abortive period. Hypertensive disorders of pregnancy was associated, whether it was mild or severe preeclampsia, again mild, severe eclampsia, others. Labor-related disorders, whether she had a prolonged labor, obstructed labor, ruptured labor, or an inversion of uterus, retained placenta, or any other labor-related cause. Medical disorders, which could be anemia, heart disease, LRTI, diabetes, and others. So these are the things which are talked about. The section 8 talks a lot about her antenatal period. Did she receive an antenatal care? If yes, number of visits, no or not applicable at all. Suppose she is a rupture ectopic who just walks in, so you might not suspect that she would have received an antenatal care. You can put a not applicable mark here. If yes, what was the type of the care provider? Whether she just visited a nurse all the time in a PHC, whether she came in touch with a medical officer, a specialist, or in a public sector, or others, including private sectors. So the form not only pushes the patient should have had a visit with the government setup, even if it is a private sector contact with the doctor or the medical care, it is counted as a visit. So the quality of care provided, whether the eye was checked for pallor. Now, after reading the form thoroughly, you might be understanding how deep and elaborate this form is, and so much information you can gather about the patient and how was her antenatal care throughout the pregnancy. A lot of inputs have gone into building up this form, and it is really important. Whether the BP was taken, abdominal examination done, whether the was urine checked, HB was checked at least once during her antenatal visit. Was she informed about problems in present pregnancy, yes or no? So these are the questions which only a woman whose life can answer to you. Suppose it is a maternal mortality, you might not be able to check half of the information. Because it was a near miss, you can ask the woman directly whether she was given such kind of care. So was referral made to the appropriate facility or not? Was referral slip with details available? What was the reason? Was it a lack of awareness, lack of accessibility, lack of fund, lack of attendee? Some women come to you and say कि मेरे साथ जाने वाला कोई नहीं था hospital, so I could not visit a hospital, and she might have thrown an eclampsia fit at home. So that is also an important social contributing indirect cause of either a mortality or a morbidity which can be identified. Then there could be family problems where there could be intimate partner violence or domestic violence that could be happening with the woman out there. Significant past history where we talk about personal, medical, surgical and obstetrical causes, gynecological causes or any kind of family causes with details to be mentioned here. So the complaints, the durations all these complaints are asked to the woman in detail and for how many hours and days that these conditions persisted and when was the necessary action taken. So these are the examination findings at the time of admission and at the time of near miss. Temperature, pulse, respiratory rate, blood pressure, pallor, icterus, cyanosis, clubbing, all general physical examination, CNS examination, CVS examination. You can take this as a basic thing for your long case and long vivas also, because it is such an elaborate thing. Once you know this thoroughly in and out, you will not miss out on any examination findings in your long case as well. So respiratory findings, any cardiovascular abnormality that could have been detected, abdominal findings which talk about fundal height, uterine contractions, whether they were present or absent, presentation, position, estimated baby size, like a fetal heart rate. Other abdominal findings could be of distension, scars, whether it was guarding, tenderness, or ganomegaly, lump. All rupture ectopic fall into maternal near miss. Remember that. Per speculum examination, cervix, vagina, others, per vaginal dilatation, effacement, position, consistency, station of head, membrane status, lighter, and others. So these are all the vaginal findings, and other findings are also recorded. So this is all about examination. The second half of it talks about investigation. So first part we saw about the signs and symptoms. Second part of the diagnostic criteria includes examination. Third comes as investigations, which is blood, urine, blood sugars, blood sugar levels, LFT, AFT, infectious disease screening in cases of women who had sepsis or suspected septicemia, fundus examination with ophthalmoscopy in cases of preeclampsia or suspected raised intracranial pressures, and other imaging findings with an ultrasound, Doppler, and X-ray, CT, MRI wherever indicated. The other form, the 13th segment of the form, talks about delivery details, whether it is known, unknown, or even not applicable. As I said, this post-abortal, it would be not applicable. What was the place of delivery? Did she have any kind of labor pains and indication for induction, duration of labor? Everything is being thoroughly discussed here. Next is about the type of delivery, whether it was vaginal, cesarean, assisted with episiotomy, forceps. Everything has to be mentioned in detail. It also talks about anesthesia and any adverse reaction. Some near misses are because of anesthesia-related complications. They might not have any kind of obstetric or medical or surgical complication. They might be anesthesia-related complications, which also have to be investigated. In which phase of labor did she develop complications post-birth, within 6 hours, 6 to 24 hours, or after 24 hours, or the first stage, or not applicable? What is the complication like? Atonic PPH, traumatic, cervical, vaginal pain, and tears, broad ligament, hematoma, rupture, uterus, intrapartum eclampsia, artery, placenta, or others. Next is about who conducted the delivery. Then is perpurum, postpartum, post-abortal, post-ectotomy, and blood transfusions, whether she received or not, and what was the quantity of blood transfusions and different units that she received. Then it is important to discuss about the details of the baby, whether the baby received an ICU admission or not. And lastly, we discuss about the system involvement, whether it was a system, single organ involvement, or it was a multi-system organ involvement. Finally, we discuss about the condition at discharge, whether the woman has completely recovered or not. And if no, what was the details of the residual morbidity? So these are the interventions that we talk about, and also the type of interventions. The third segment came about interventions. First is clinical findings, second is investigations, third is interventions. Whether she required ICU admission, whether she required mechanical ventilation, she required any kind of vasopressors, was she on adrenaline, non-radial support, whether she required any kind of laparotomy for atonic PPH, whether she underwent hysterectomy because of her placenta accreta. So all placenta accreta spectrum patients who undergo hysterectomy fall under maternal near miss per se as such. Repair of genital injuries, dialysis, management of ketoacidosis, anticoagulation therapies, personal family involvement, logistics, referral facilities, present facilities, and also finally the signatures of the unit consultant, unit in charge, and whoever has filled the form, and name of the nodal officer with designation and institution have to be filled. So these annexures will be provided. Sorry, it is on a landscape mode. I just wanted to show you, we'll not read each one of them. It is just about what are the adverse events, whether it was hemorrhage or abortion, or the disorders prior to the complications, symptoms, signs, then results of the investigation and intervention. So again, 3 clinical findings, investigations, and again interventions. The ones which have a heart adjacent to them, even one of the heart which is being there, so it automatically fulfills the MNM criteria. So here the adverse events are hemorrhage. If you can see the last vertical column, which is hemorrhage, sepsis, hypertension, postpartum collapse, liver dysfunction, failure, cardiorespiratory function, anemia. These are the pre-existing disorders aggravated during pregnancy. Could be anemia, respiratory distress. It could be cardiac dysfunction, hepatic dysfunction. So because it is such an elaborate list, we are not discussing each one of them. It could be a thyroid crisis. So these are the things which are elaborately covered under MNM criteria. And this is the MNMR register, which is to be filled by the institution and the district.